Okay, we're going to get started. Again, if you have questions, please walk to the mic in the center of the floor. We're going to start the training with reason for referral. Go ahead. Reason for referral is very, very important because not only, remember we talked about the medical necessity statement, what is at risk, the reason for referral also helps establish medical necessity. In your reason for referral statement, you should always start the sentence off with patient was hospitalized for in the medical diagnosis. So you always want to include the hospital date and with the medical diagnosis. If you don't want to include the hospital dates, you need to still say the patient was hospitalized for whatever that medical diagnosis was or is. You have to document the issues or problems related to your discipline. So if the patient has had a decline in ability to communicate, a decline in memory, or has had a decline in dressing, grooming, bathing, ambulation, that's what you should say. But it only has to be, it cannot be related to anybody else's discipline. That's number 2. Physical therapy. It is important that you document the primary mode of mobility. That helps establish functional mobility. Establish functional mobility. It helps establish medical necessity. For example, if you're working on gait and prior level of function, patient was ambulating independently at home without any assistive device, and the primary mode, patient is currently in a jerry chair, that's going to really help establish medical necessity. So physical therapy, you need to always document the patient's current mode of mobility because that helps paint a picture and helps establish medical necessity. And last, you need to include a statement of medical necessity. What is the patient at risk for if services are not received? Make sure when you're documenting your issues or problems related to your discipline, write this down. You need to look into your assessment and take the severity level or the current level of function and include that. If the patient currently is at max assist for toileting or max assist for dressing, and those are the deficit areas in your reason for referral, make sure that you include the current level of assistance or the severity level speech. Mild, if they have a moderate swallowing problem or severe swallowing problem, that's what you want to say, because that's going to help establish medical necessity. So these are the 4 areas, and number 3 is only related to PT. Okay, for part B, you want to document how the referral was obtained and who referred and when. And now, if the Part B patient had a hospital stay, because some Part B patients do go to the hospital and come back. If they had a hospital stay, you're going to follow the hospital, document the hospitalization with the medical diagnosis. But if they have not, you want to document how the referral was obtained. You want to say why the referral was made, for example, due to a fall or a choking episode, and what happened. You want an accurate description of the resident's functional issue or problem, like a decline in balance or inability to swallow thin liquids or an inability to swallow medications or whatever that was. Make sure you include the current level of assistance or the severity level, and you can take that straight out of your assessment. Okay? And you always want a statement of medical necessity as well. What is the patient at risk for if services are not received? You got the hospitalization dates with medical diagnosis, the current issues and problems, along with the level of assistance or the severity. PT, always include the current mode of mobility, and always write a statement of medical necessity, what the patient is at risk for if they do not receive the services. For Part B, it's the same. You just want to document how the referral was obtained. Patient was referred by nursing on this date secondary to a fall. Patient requires max assist for balance and transfers and is dependent, is on total assist for ambulation. Without skilled physical therapy services, the resident is at risk for an increased burden of care by CNAs. Okay, let's look at some. All right, in your packets, you will have received, I think you all have copies of this. This is a reason for referral a physical therapist. It says, and I want you to, as I read, listen for the components. Because the breakout session is you all will rewrite this reason for referral. There's one for PT, one for OT, and one for ST. So the PT reason for referral reads, this 79-year-old female presents to therapy with a decline in ADLs of functional transfers, bed mobility, and ambulation due to a recent, whatever that is, surgery she had gallbladder surgery, I think, on 1/4/12, hospitalization through 2/1, causing the functional decline and weakness. So we have a hospitalization and dates, very good. We know why they were hospitalized, that's their medical diagnosis. They also did a great job with including the deficit areas. We know she has a decline in transfers, bed mobility, and ambulation. Excellent job. Another component. Nursing and caregivers have noticed a decrease in self-care ADL's ability for the past month. Now, what's wrong with that? Is self-care part of PT scope of practice? No, it's not. Remember, it has to be related to your discipline. And I'm going to tell you why you need to stick to your scope of practice on your 700. We had an incident where speech was working with a patient on expressive language and cognition. OT took it upon themselves in their 700 to talk about cognition. Patient is able to communicate and all this good stuff. Claim was pulled. Every charge that speech therapy bill was denied because OT documented they didn't have a problem. You stick to your scope of practice. You don't mention anything about anybody else's scope. You stick to yours. Okay? It is very important that you do that. So now we got PT talking about OT stuff. OT may have documented, and these are the same residents when you see this. OT may have documented they didn't have a problem in dressing and grooming, but PT done documented there's a decrease. Stick to your, so that sentence is not needed. That's not in your scope, so don't mention that. Okay, resulting in decreased safety and increased need for assistance. Patient requires skilled therapy in order to improve safety and function. They told why, they just worded it differently. Let's go on to the next one. So we've basically talked about how can this be improved. I want you to just hold that. Let's go to OT. This is OTs. This is the same resident. Patient entered SNF after recent hospitalization, gallbladder surgery, patient with a decline in function. This is the same resident. That's the reason for referral. Let's go to speech. This is the same resident. This 79-year-old male presents to speech therapy with impairments in cognition for the past several weeks due to altered mental status. The patient has shown a decline from intact cognitive function to intermittent confusion and moderate cognitive function in ADL. Speech therapy service is necessary to improve cognition in order to increase independence for functional tasks and prudent decision making. That's a good risk factor of what would happen to the patient. One of the things I do want to mention about this, when documenting your reason for referral, you want to be as specific as possible. You want to avoid things like functional mobility because it means transfers, it means ambulation, it means balance. You want to avoid words like you can sum up cognition with moderate impairment like you should, but cognition includes memory, problem solving, reasoning. It includes all those things. So you need to be specific when you use the word cognition. Self-care is the same thing. Self-care means grooming, bathing, dressing, toileting, hygiene, all of that's self-care. So you need to be specific with the problem area. And all you need is one deficit area or one problem area to warrant an evaluation. Okay, so how can we improve the reason for referral? I want the physical therapist on this side. You have a sheet in your packet that says reason for referral. I want PTs to take the PT, reason for referral, and I want you to improve it. It should have all the components that's listed. It was pretty good the way it was, but it was lacking something, one area I do believe. Speech therapy in this section, I want you to take the speech therapy reason for referral, and I need you to make this a valid reason for referral. It needs to include all the components. And you all should have, you all have it in front of you. What's on the slide is what you have in front of you. You should have one for PT, one for OT, and one for ST. The PT is just work on physical therapy. The speech, you're going to be working on speech. And OT, you need to work on OT. Each table need to collaborate because we're going to ask each table to read their reason for referral. So you need to work together as a group. Managers, if you want to help them out, you can. So I need you all to collaborate as a group, and I need you to come up with a reason for referral, and it needs to include all the components. And this is a Medicare Part A resident. And let's go back to the components. Those are the components that's up on the screen, yes. Oh, they don't have a plan of care. Deborah. We need a plan of care for this table. We need a handout with the plan of cares on it. All of them are stapled together, but a PT. It needs to be a physical therapy one. Well, I can just take speech because speech is not working on the PT. Here, give me this plan of care. Hold up, let me take this. Speech, OT. Oh no, this is all speech stuff. Y'all don't have it. Yeah, physical therapy. She's bringing it. So you all have 5 minutes. Remember, here are all of the components. So we just y'all need to collaborate as a group. One person needs to write. And each table needs a spokesperson because you will come up to the mic and you're going to read it. Y'all have 5 minutes. PT should be pretty easy because most of their stuff is already in theirs. Speech was pretty easy, should go pretty fast because it was written sort of well. It was lacking a few, but OT, y'all need to start from scratch. Y'all see the hospital dates are already there. Medical diagnosis is already listed. I left that for a reason. Hey, Chris is going to take a mic, and Deborah's going to take this mic. We're going to alternate tables. Chris, we're going to start over with the physical therapy side.
We're going to start with Rochelle or Janice.
All right, we just need the spokesperson to read it.
They want a little extra time at this table.
Okay, just go to another table then.
All right, here we go. Who's going to speak here? Better start on that side, Zandra.
Okay, we're going to start with speech. Woo-hoo. Let's get started. Speech. We're listening for all these components.
Okay.
It doesn't, well, we don't know because PT said it was a male, OT said it was a female.
Okay, we're going to say,
we don't know.
this 79-year-old was hospitalized from 1/4/12 to 2/1/12 secondary to gallbladder surgery. Following surgery, patient began exhibiting decreased attention to task, poor memory, delayed recall, sequencing, and problem solving. Patient also exhibited moderate dysphagia characterized by mild pocketing. Skilled STDT is necessary to improve cognition in order to communicate competence and to facilitate safe swallow without signs and symptoms of aspiration.
Excellent job. I heard number 1, number 2, and number 4. That's what's supposed to be there. OT? PT. Okay, physical therapy.
Okay, we said that it should say this 79-year-old female presents to therapy with a decline in ADLs, functional transfers, bed mobility, and ability to ambulate. All that's good. But that we would take out the self-care and then put that the caregiver and nursing had noticed a decrease in safety and an increased need for assistance with bed to wheelchair transfer, ability to ambulate, and be more specific with the actual tasks on that part. And that without physical therapy services, they were at increased risk for increased burden of care, continued muscle atrophy, and list out some of those things.
Okay, so let's go back. Let's go back to the problem areas. Remember, I had you to include the level of severity. So make sure you say what level of assistance they need for bed mobility and transfers. They require max assist, mod assist. And lastly, physical therapy, number 3. You have to put number 3 in there. What is the patient's primary mode of functional mobility? Physical therapy, it's required. You need to put that in there, especially if you're working on ambulation. Okay, ready for OT?
This 79-year-old male was recently referred to skilled nursing facility after hospitalization between 1/4 to 2/1 for gallbladder surgery. Patient and family has noticed a decline in transfers, activity tolerance, balance, and overall functional performance. Without skilled OT service, patient would be at risk for increased dependence on nursing staff for all ADL tasks and safety.
Very good. There was one thing I didn't hear, what was missing. It's not on the slide, but I talked about current level of assistance or severity level. Just say patient requires max assist for transfers, whatever.
Thank you.
Very good, excellent job. Physical therapy,
We seem to have some,
speech, I need a speech. Or another OT, Back table's ready.
here we got a speech right here.
Oh, we got a speech right here. Okay, let's go with speech.
We didn't necessarily get finished, but this 79-year-old male presents to speech therapy with cognitive impairments beginning 1/4/12 to present due to altered mental status. This patient demonstrates a decline from intact cognitive function to intermittent confusion and mod cognitive function and ADL. Skilled ST services necessary to improve oral motor strength, cognition, expressive receptive language skills, secondary to following commands, attention, recall, problem solving, and safer feeding and swallowing skills.
Okay, I see you broke them down later because I remember we talked about cognition is so broad, you got to break them down, but thanks for breaking them down in the end. Very good. Next.
Right here.
Oh, yeah, sir, did you document that she'd had surgery for gallbladder? Remember for Part A, yeah, remember to include the medical
They
diagnosis.
didn't do that.
Okay, medical diagnosis was missing. Make sure you guys, that's real important. Next table, Deborah.
Hey.
Okay,
Ready? Hey,
OT? Everybody listen.
patient is a 79-year-old male admitted to this facility on this date. I don't have that information. Patient with recent decline in health, function, and safety following recent hospitalization secondary to cholecystectomy. Feel patient will benefit from skilled OT services to address ADL, which is bathing, dressing, grooming, safety, functional mobility, transfer bed mobility, and sitting balance.
Okay, what about the level of assistance? Is the current level of assistance required, that they require max assist in those areas? Is that documented in your,
It's documented probably.
read
no.
it? It has to be documented in the reason for referral. Read the part where, is it there? If not, you need to just insert it.
Okay.
Okay, and then also, what are the risk factors? Do you have a medical necessity statement? Without skilled OT, what's going to happen to this resident? Wait, give her the mic back, Deborah. Medical necessity. Without skilled OT, the resident is at risk for what?
Okay, so you put the risk factors under
Yeah,
that too?
without skilled OT. Remember, you got to have a medical necessity statement.
With ours, that's a check box that we click. So are we supposed to type out, that's the same thing with prior level and current level of function. We normally don't write that in that part. It's on a separate part.
Well, okay,
Because
this
so
training.
we're supposed
guys,
to state it twice.
Yeah, let me say this. Let me just say this, you guys. It is much better for you to paint the picture and tell the story to Medicare opposed to having the Medicare to look for these boxes on your form. Because if they have to look for it, they got to pull it together. And if they got to pull it together, they're going to say, not medically necessary. And you're going to say, what are you talking about? It's right there, and then you have to fight a claim. It's better if you write it and include it, you tell the story, it's right there in front of them. They go, why do I got to put the hospital dates? It's right there. Why do I have to put the medical diagnosis? Can't they see it at the top of the form? They're looking all over the place. Medicare is not going to do that. I'm going to tell you that right now. If Medicare cannot read it verbatim and it tells a story, they're not going to go all over your paperwork trying to piece the story together. They're not doing that.
So basically, let me just check
You rewrite it.
clarify. You're gonna, in the reason for referral, you're gonna say why they're there,
Yep.
what their current, basically, you want that to be a summary of the entire evaluation,
Yes.
just restate it and then restate it.
Yes.
Okay.
And it's easy because when the current level that they're functioning at is in your assessment box, because you just did it. You just pull that mod max out of there. So all of what you need is right there in front of you. The hospital dates are right there. Medical diagnosis is right there. It's not a problem. You write it and tell a story. All right. OT. This is going to be, we're going to get another physical therapist. Okay. Go ahead.
Patient is a 79-year-old female, recently hospitalized. And do you want the dates?
Go ahead.
Okay. 1/4/12 to 2/1/12 for gallbladder surgery resulting in decline in activity tolerance and now requiring maximum assistance with bathing and dressing, unable to return home at this time at prior level of function, and will benefit from caregiver-patient training to maximize safety, decrease fall risk, and maximize return of independence with recommendations for assistive equipment as indicated.
Okay. Very good. That's good. All the components heard. Next, physical therapy. We're going to take one more. We got a PT. Ready, PT?
This is a 79-year-old female presents to therapy with decline in functional mobility of transfers, ambulation, and bed mobility due to recent gallbladder surgery on 1/4/12 and hospitalized through 2/1/12, causing decreased functional independence and weakness. Nursing and caregiver has noticed decreased independence with transfers and ambulation with a rolling walker for the past month, resulting in decreased safety and a need for moderate assistance. Patient requires skilled therapy in order to increase safety with gait with assisted device in the home. Patient at risk for falls without skilled PT intervention.
Very good. What's their primary mode of functional mobility? Rolling
walker.
walker. I thought that's what I heard. Very good. Excellent job. This table.
OT?
OT, right here.
PT? OT.
I need a speech.
All right, patient is a 79-year-old female presenting with a recent hospitalization from 1/4 to 2/1/12 from gallbladder surgery resulting in safety risk secondary to risk for frequent falls with further decline in level of functioning. Patient with deficits of decreased self-care, including max assist for transfers and min to max assist for bathing, dressing, grooming, and toileting. Patient also demonstrates decreased safety awareness and decreased safety with static and dynamic balance. Patient would benefit from skilled OT services to address these deficits and safety risk in order to return to prior level of function and decrease burden of care on staff and family.
Excellent job. Speech, right here.
Oh, man, I'm not through yet. The 79-year-old male was hospitalized for gallbladder surgery on January the 4th, 2012. Patient had been living at home independently by himself. He had a sudden onset of severe GI issues requiring hospitalization and surgery. Patient presents to skilled ST services with a decline in cognition in the areas of short-term memory, decision-making, temporal spatial orientation deficits with confusion. That did not resolve within a week. Patients, let's see, after surgery, patient began exhibiting coughing and choking on liquids and solids, had lingual deviation to the left, negative reaction to certain food textures and consistencies. Patient's PO intake had declined significantly. Patient is at risk for aspiration, dehydration, malnutrition, skin breakdown, requiring skilled services of ST to avoid risks of aspiration, improve oropharyngeal efficiency, establish least restrictive diet, and teach compensatory strategies. And that's as far as we got.
Okay, that's excellent. That's excellent. That was a lot, but that was good. Speech therapists normally write a lot, y'all. They give a lot of detail. That was excellent, though. Y'all, let me just say this too. I need to mention this for speech. When you're working with swallowing dysphagia and you're working on diet consistencies, make sure you document the resident's current diet. If they're MPO, if they're on a puree with thickened liquids, make sure that you document that, because in the prior level of function, we should see that the patient was, prior to this incident, they were on a regular diet with thin liquids with no swallowing problems. And that's the purpose of documenting this way, because we are establishing medical necessity. Prior level of function, they were living at home, ambulating independently. Now they are in a jerry chair. Or their NPO, reason for referral, with all these swallowing issues, prior level of function, they was on a regular diet with no swallowing problems. Those two together, they work together. Prior level of function, I'm normal. Reason for referral, there's a problem. The reason why you need to put the level of severity in there, current level of assistance or severity level of speech, is so that we can see the comparison. No problems, mild problems, or max problems, or severe or profound. That's the purpose of it. Those two boxes help establish medical necessity. Next, who has the mic? Deborah? Okay.
This is a 79-year-old female presenting to therapy with a decline in ADL tasks requiring minimal assist with grooming and hygiene, moderate assist with upper body and lower body dressing, moderate assist with bathing, moderate assist with toileting, max assist with toilet transfers, and max assist with wheelchair to bed transfers due to a recent cholecystectomy surgery on 1/4/2012 hospitalization through 2/1/2012, causing decreased balance, functional decline, decreased endurance, decreased safety awareness, pain, decreased upper body strength, and decreased range of motion, upper body range of motion. Nursing and caregiver has noticed a decrease in self-care and ADL abilities for the past month, resulting in decreased safety, increased need for assistance, and increased burden of care. Without skilled OT, resident is at risk for increased dependence on others for care, further decline, and a risk for falls.
Very good. Y'all look good. This is so good. We got another one. Anybody else? Okay, physical therapy. We're going to take one more physical therapy and one more OT.
The 79-year-old female presents to therapy with a decline in ADLs of functional transfers, bed mobility, and ambulation due to a recent cholecystectomy surgery on 1/4/12 with hospitalization through 2/1, I guess that should be 12, causing functional decline and weakness. Nursing and caregiver have noticed a decrease in functional mobility for the past month from ambulating independently with rolling walker at home to wheelchair as primary mode of functional mobility, resulting in decreased safety and an increased need for moderate assistance. Patient requires skilled therapy in order to improve safety and function to reduce fall risk.
Excellent job. Y'all are doing so very well. Wow, this is good. Give yourselves a hand. I'm so happy. Make sure you guys, so when you go back, don't forget about all of these components. Okay, so okay, now we're at prior level of function. Prior level of function also helps establish medical necessity. It is a baseline of information that will help guide the therapist with establishing goals and a plan of care towards the expected outcome. Your prior level of function or insufficient documentation of prior level of function is one of the top reasons that Medicare will deny a claim. A patient's prior level of function is relevant because when you write that long-term goal, it should look just like the patient's prior level of function. It should be as close to the resident's prior level of function as you can get it. And that's why your prior level of function, again, should be related to your discipline. Speech therapy, I shouldn't see y'all talking about ambulation and bathing. I have seen that. Unless you're going to write your outcome, your long-term goal is going to be about ambulation and bathing, and it's not. So you don't include that in your prior level of function. Your prior level of function has to relate to your discipline. It should start off with where the resident lived, whether they lived alone, at home, or in a SNF, and You should also document anything specific that will help you in developing your plans. For example, stairs and doorways. Because if a resident is going home and they have stairs that they have to negotiate, you need to include that in your prior level of function, because that's going to paint a picture as to why you're working on stairs when your nursing home doesn't have any stairs. And so make sure that you include that, or ramps. Your prior level of function should also, you should document the prior level of function for the problems that you mentioned in the reason for referral. So in the reason for referral, if you said that the patient required moderate assist for bed mobility and transfers, those two things you have to mention in the prior level of function. And any other things that you want to mention related to your discipline. So speech, if you said that they had impairments in memory and problem solving and swallowing, in your prior level of function, you have to document their prior level of function for memory and swallowing. And you can mention any other things, but the problems and the reason for referral that you mentioned has to be in the prior level of function, because they have to compare those two. I don't know that just because a patient was max assist for transfers, if it's really medically necessary, because if their prior level of function was max assist, then it's not medically necessary for you to work on that. And that's why they have to see that. Prior level of function has to be some type of normalcy. Reason for referral has to be a problem. If they were ENPO at home and they ENPO now and they've been ENPO for 4 years, they don't see a medical necessity for working on that. Now, there are some rules that you can, but you got to have some sound documentation to back it up as to why you're doing it. That's the purpose of documenting the way we just stated in the reason for referral and the prior level of function. Those two boxes together work together. Your PLOF should look just like your long-term goal. Yes. Walk to the mic. Sorry. Right here in the middle. Sorry.
I just wonder what your opinion is on this. When the prior level of function was not really established, or they didn't have the appropriate therapy, the appropriate intervention to get them there, if you see more potential, is it okay at that time to state, you know, what you perceive to be their
your clinical expertise and not,
right.
You can document that, because there are some instances where a patient may have had previous therapy but didn't make the progress, and say it was an old CVA and they're in the facility now, they can't communicate their basic needs. In the prognostic statement, you can document that it is your clinical opinion that the patient will make excellent gains, and it will be fine. Okay, so prior level of function. Make sure the prior level, you document the prior level of function for the problem areas that you documented in the assessment section in Cassandra, because you all put that in your assessment section. You need to take whatever the prior level of function was in your assessment, you're going to pull that piece out, that they were independent, man assist, that's what you're going to write in your PLOF area. You must have a prior level of function and current level of function for all areas that you plan to address. And this is in your assessment section, all right? All right. So let's analyze some PLOFs. Here's one for PT. Patient is a long-term care resident of a SNF and was previously able to perform all functional transfers with supervision and ambulation in a rolling walker times 200 feet with standby assist. OT, resident lived at home with cousin and required minimal assist with dressing, bathing, and grooming. So what they do is they take the PLOF and they compare it to the reason for referral. And the reason for referral, if they were max assist for dressing, bathing, and grooming, prior level of function, they were min assist. So this patient's long-term goal for bathing, dressing, and grooming is going to look like min assist. ST, resident lived at home alone. She was on a regular diet, thin liquids, with no swallowing problems, and was able to communicate all basic needs and wants independently. So that's what a good prior level of function looks like. So let's look at the prior level of function for your residents. I want physical therapy to take PT, OT, you work on yours, and ST, you work on yours. So you want your prior level of function. Now, take in consideration what you wrote in the reason for referral. Your prior level of function, you should be able to look in the assessment box and pull the prior level of function out and write it. Okay, you all have 2 minutes. Russell, let me know when the 2 minutes are okay. You have 2 minutes. He's my timekeeper. All right, time is up. All right, we're going to start with Chris. Get the mic. Kim. All right, let's start over here with speech. Remember, your prior level of function got to stick to your discipline. All right, ready for speech.
Kim's going to do it.
Go ahead, Kim.
Well, patient lived at home with minimum requirements for medicine or medical management and appropriate level of judgment and safety. I really wouldn't.
Okay, you weren't finished. Yeah, because in your reason for referral, you talked about decision-making and all that. Yeah, so you got to tie that. Although, you know, medication and all that is part of it, but Medicare doesn't know that, so you got to tell them that. Next. Right here. Go ahead. OT?
Okay. Okay.
Come on.
Patient is a 79-year-old female living at home alone with caregiver as needed prior to hospitalization. Patient reports he needed occasional assist with self-care activities set up to independent. Patient reports being independent with transfers and toileting. Patient would benefit from OT to address his current level of function as max assist for transfers and min to max assist for all self-care in order to increase his independence and return to prior level of function.
Okay, now remember that was good, but remember you also had a medical necessity statement in there. You didn't need that. That goes in the reason for referral. So remember in your prior level of function, you just want to tell where the patient lived, did they live at home alone, and their prior level of function rated in severity or current level of assistance. That's it. Okay? Next. Okay, over here, we got OT. Okay, Juan. Is it on? Hit the button at the bottom of the mic. Push it on. The light should light up in the middle.
Okay. Patient lived at home alone with caregiver assistance. Patient was independent with grooming. Lower body dressing and bathing was set up. Modified appendix with toileting.
Excellent job. Next, right here, physical therapy.
Okay, patient lives at home with spouse, independent with transfers, min assist with bed mobility, and independent with gait with straight tip cane on level surfaces.
Excellent. That's it. Next, we have a mic back here. Okay, here we go. OT. Hold it up. Hit the button at the bottom of the mic. Turn it on. Okay, we got a PT while you turn it on. Go ahead, Belinda.
Patient lived at home with caregiver or cousin and was modified independent with Roland Walker within environment of home, supervision on multi-surfaces outside of the home, all transfers, modified independence.
Very good. Excellent. Right here, OT with the mic.
Patient was independent to set up with ADLs and independent with transfers, fair static and dynamic balance, minimum impaired cognition and safety, low risk for falls.
Where did they live? Table, OT table, where did the patient live? You missed that. Remember, you always got to tell where they lived, if they lived alone, if they lived at home alone or with the caregiver. Make sure you write that in there. Handwrite that in there. Okay, next.
Patient lived at home independently and exhibited appropriate memory, attention, recall, and sequencing. Patient was able to consume regular diet with no signs and symptoms of aspiration.
Excellent job. Next, right here. Speech.
Here we go.
Patient lived at home independently, managed his own medications, demonstrated no signs and symptoms of decreased cognition, able to communicate wants and needs, and managed ADLs with only occasional help from family. Patient's diet consisted of PO intake of regular diet and thin liquids with no signs and symptoms of dysphagia.
Okay, let's talk about, she mentioned managing ADLs. Are you OT? Okay, draw a line through that. Line that out. You got to stick to your discipline. Remember, what you write in your prior level of function is going to drive your long-term goal. You all should never have a problem coming up with a long-term goal because it should look just like the patient's prior level of function. And if you say, well, I can't put that in a long-term goal, then it shouldn't be in your prior level of function. Okay, next. Okay, wait, we got a PT. Ready? Go ahead.
Patient lived at home alone with caregiver assistance and was previously modified independent with ambulation using rolling walker, transfers, and bed mobility. Patient did not require assist from his caregiver for overall functional mobility before his hospitalization.
Very good. OT. We got another OT?
Patient lived at home with caregiver/cousin and required setup for lower body dressing, setup for bathing, and performed toileting with modified independence using elevated toilet seats. Patient required occasional assistance for shopping, housekeeping tasks, and meal preparation.
Very good. Okay, we got one more. We got right here. Speech, right here, Chris.
I'm sorry, they don't want to.
Okay, we're going to take one more speech.
Okay, speech. Patient lived at home independently on regular texture thin liquids with no reported swallowing difficulties, able to communicate basic and complex wants and needs verbally, able to cognitively manage finances and household with adequate memory, attention, safety awareness, and executive functioning. Patient managed medications with family Menassist with medication and Mediset, family checks once a week.
Excellent job. Y'all give yourselves a hand. This is fantastic. This is excellent, excellent documentation. So now that you know, you have a good understanding of reason for referral and prior level of function. I need you all to look at this assessment. There are some items that you need to watch for. And I want you to just pay attention to the speech assessment. We're going to just work with this for just a second. Remember, speech talked about the patient having swallowing problems. It was in the assessment. You want to ask, what was the patient's prior diet level? That was lacking, but you all fixed that. That it was noted on the evaluation. If you look at the evaluation, speech documented that the patient had moderate pocking. But when we get to the goals, you're going to see that she didn't address it. There was no goal for swallowing. So you want to watch things like that. Speech pathology. Speech therapists, speech pathologists. When you do an evaluation, even if there is one goal, if you document a swallowing problem, whether it's pocketing or whatever, you need to bill for a speech evaluation, you need to bill for a swallowing evaluation, and you need to treat that swallowing problem. Is that clear? Because a lot of times we see this, and you've noticed on this particular one for speech, this patient had a problem. But the speech pathologist didn't even develop a goal for swallowing. So when even if it's one problem, you need to bill for a speech evaluation, a swallowing evaluation, and you should be treating. You need to establish a goal for that swallowing problems, and you need to bill it under swallowing treatment. Okay? You clear on that? You kind of got a frown on your face. Okay. All right. Yes. Question? Come to the, I didn't.
So what about if you're doing a swallow eval and you're writing about the swallowing abilities and you have maybe a pull down about their cognitive status, maybe someone with dementia? Is it vice versa? You also have to have a cognitive goal, but you don't expect that cognition to improve with this patient?
Well, then you need to bill for a speech evaluation, and you need to address the cognition in your evaluation. It needs to be documented. And I think when you set these goals, when you set them up, there's a button that you can put baseline only, that you're not going to establish a goal for that. But you still need to bill for that speech evaluation to cover the cognition. And if you're working on swallowing, you need to bill for the swallowing evaluation to cover the swallowing.
Now, some aspects of swallowing are cognitive, so you would naturally put that on a swallowing evaluation, but you wouldn't bill a speech evaluation with that, would you, if it's just part of the swallowing evaluation?
If you're just looking at their ability to follow directions and that's it, no, then you wouldn't. But I'm thinking, okay, yeah, if it's just following directions, no. But if you see some other problems, that it's memory and problem solving, and you're going into detail, then yeah, you would need to build that. But if it's just following directions, no. Okay. Yes. Wait.
When should OT develop a program for cognition, or do we?
Well, let me say, you can develop a program for cognition if you don't have a speech pathologist working in your building. Is that clear?
I knew we shouldn't.
Because I know OTs do work on cognition, but if you have speech therapists working in your building, you shouldn't be working on cognition. And before you write something negative about somebody's cognition, communicate with your rehab, with your speech pathologist, and this should be going on during your rehab meetings, or just so to make sure, if you need to mention it, that you're saying the exact same thing that the speech pathologist is saying. Wait.
Like standing balance, and transfers.
Okay. All right, here's the deal. Your transfers and your balance has to do with the functional outcome. You could be, physical therapists could be working on transfers to get them from their bed to the wheelchair. OT may be doing transfers to get them from their chair to the toilet. It all has to do with the functional outcome, because everything you work on must have a functional outcome. There's a reason that you're doing it, and it must be something functional. So PT does not work on, PTs normally don't do toileting and toilet hygiene and things like that. So you're doing transfers related to what you treat, and PT is doing the transfers for what they treat, and it's totally different things. And what differentiates it is the functional outcome. Everybody clear on that? Yes.
Yes, when I'm seeing a patient, they're like, I have to go to the bathroom, and I take them to the bathroom, and I'm documenting about everything I'm doing. I'm not PT, but I'm still talking about transferring to the toilet using the grab bar and,
What
yada,
are you?
yada, yada.
PT.
I'm a PT.
You can do that.
Okay.
As long, and what I would do is that I would document, I would take it a step further and say that I notified OT how the patient is making progress with the toileting skills, because that shows progress.
Okay. And sometimes they're not even on an OT
And so,
caseload.
you're right, sometimes they're not, and maybe the reason why they're not, because they really don't have a problem with it, but you're not working on the toileting skills, you're working on transfer.
Unsupported sitting balance.
Right, okay. All right, any other questions? Okay, let's move on. Let's talk about medical history related to the, yes. Oh, another question.
I got one that mainly refers like with the ADLs and stuff like that. When you're talking about like PT, you're not referring to ADLs. So when you're talking about patient performed, dynamic standing activities to help increase functional activities / ADLs within the facility, is that not something you can put either?
What's your discipline?
PT.
Activity tolerance. You should be doing activity tolerance related to endurance, related to gait, so that they can ambulate. Because they're going to need to.
The facility is just not one of those type of places. This is not a place that they're ambulatory is not a big thing, for one, because half of them can't ambulate.
So what is your primary reason for working with this patient? I'm just saying, because that's what you have to do. Whatever the patient's primary problem is, that's what you need to tie the endurance to.
Well, see, when I put that in, because I also put it as like, they're getting up to do their ADLs and opposed to sitting down and doing their ADLs.
Are you PT?
Yeah, but they teach us ADLs in school.
Yeah, I know, but then in this, are you in what setting are you in? Assisted living?
Part B.
You're Part B, okay.
Psychiatric.
So what you have to do is that a patient needs endurance and balance for I guess what I'm trying to say is that you have to look at, because ADL doesn't mean anything. ADL is broad. And Medicare does not want you to use broad terminologies. Activities of daily living means grooming, bathing, dressing, toileting. Is too broad. So first of all, functional mobility is too broad to improve. It's too broad because it can mean toilet transfers. It can mean ambulation. It means a lot of things, just like cognition. So those are words that we need to stop using ADLs, and whatever you need to pull out, whatever the specific thing is. Now, my question to you is, if you're saying that you're going to be using that for dressing, you're going to have to physically go and observe dressing and get the patient dressed in order to really measure that, and you're not going to do that, right? But you probably can.
What it calls for. I mean, I just do. I
What,
don't know
what
I'm
you
trying
have
to
to,
say,
okay.
really. I mean, I list all that about endurance. You know, we're standing on a balance pad and what have you to, you know, increase their stance time to help the CNAs.
If I were you, I would stick to
increase
endurance related to
transfers.
gait. Yeah, I would stick to it related to gait. The only way I would do that is if you do not have an occupational therapist working in your area and has the same exact thing, because if you do, and you write the same thing, that is duplication of services. So that's why you have to be careful and make sure that you tie the functionality of what you're working with to something functional related to your discipline. Because if you say you're increasing, you're working on endurance to improve endurance during dressing, and OT is saying the same thing, that is duplication of services. Okay, well then you will probably be able to get away with it, okay, because there's no OT there, and that's fine. If there's no OT, right. If I were you, I would, because in order for you to measure that, you're going to have to observe ADLs. In order for you to measure endurance, and you say it is to improve ADLs, you're going to have to go and observe dressing and observe grooming. You're going to have to do that because that's what you wrote. So if you're not going to do that, tie it to gait, tie it to improve ability, right, to increase endurance, to improve ability to walk from their room to the dining room, because they need endurance during gait training too. And they got to get to their room, to the dining room, in order to eat in this assisted living place or wherever they are. So tied to something functional. They got to be able to have endurance to ambulate from their bed to the bathroom. Now, ambulation I'm working on. And the reason why they need to be able to ambulate, because they need to be able to get to the bathroom. They need to be able to get to activities. They need to be able to participate in family outings. Tied to something like that would probably be better. Okay, medical history. Your medical history, you basically just document pertinent medical diagnosis. Here is where you could tie in. Remember earlier we talked about UTIs and pneumonia. You can talk about it here where this pneumonia has exacerbated another medical condition. Medications, you need to know patients' medication. I just attended a workshop this past weekend, and there was a course strictly on medications. And I learned a lot. And there are lots of medications that will cause a patient to look like they have dementia. And they don't have dementia. It's the medication that has caused that. So you really need to be aware of the medications that these patients are on. Have a conversation with the pharmacist. When you notice all of a sudden that this patient start having memory problems, it's just a sudden onset, before you, the last thing you should say is that the patient has dementia. You should always go to the chart and look for a change in medications first. That's what I learned at this conference from these medical doctors. So when you see that, the first place you should check is the medications. And the physicians that gave this course said, never be afraid to call the physician and say, I understand that the patient has started on this medication, but I'm beginning to see these signs and symptoms. and you tell them what the symptoms are, and you ask them, is there any other medication or a lower dose that you can put this patient on? Physician says, don't be afraid to call and ask them that. So there you go. Don't be afraid to call and ask them. But that's really important, and I learned a lot from these medications. So basically, you can say see medical chart, because I wouldn't recommend you listing all these medications because they change. They are PRN. Some of them you might list it and the medication ends tomorrow. But when you see mood swings and certain changes, always say, has this patient started a new med lately? Because chances are that's what's causing it. Environmental factors, you basically just document any environmental factors or any type of family support, good family support, strong family support. Previous therapy is where you would document any previous therapy that the patient has received at your facility. If no, or if they received it in the hospital. If there were no previous therapy, just say none. And not only should you say they received previous therapy, but say if it was for swallowing, for contractures, for grooming and dressing, or ambulation. Precautions, this is important. Precautions, you need to document any precautions that could interfere with patient safety related to your discipline. The reason why this is so important, because what you document for precautions is going to transfer over to the therapy schedule, which means PT, OT, ST. When you print your daily schedule, and we're going to talk about that later, y'all probably don't know what that is, and some of you all probably do. The precautions are listed on there. So if a patient is on nectar thick liquids, physical therapy, and they ask the PT for a glass of water, and they give them a glass of water, shame on you, because you should have your therapy daily schedule there. The first thing you do is look at the precautions and say, oh no, she's on nectar thick liquids. I need to go get the nectar thick water from nursing, and not just hand her a glass of water. Speech therapy, you want to be PT sometimes. Patient got to go to the bathroom. Oh, I'll help you to the bathroom. Not looking at the therapy daily schedule for the precautions that physical therapy wrote. She's non-weight bearing. And all of a sudden she falls. Now she done broke her hip. Now she's gone to the hospital. Shame on you. That happened. Y'all laughing, but that's for real. So these precautions, don't take them lightly. You all need to tell the other disciplines pertinent information that they may need, that they will need to know. Because when you write that, it transfers over on the therapy daily schedule. Okay, so these are some examples of the precaution. Patient is at fall risk. Patient is dependent for toileting. Patient is on nectar thick liquids and can only respond to yes, no questions. Patient is only able to follow one-step commands. That's important for PT, important for OT. Speech pathologists, don't forget to document that. A lot of times for speech, I'll see at risk for falls. Well, PT has already said that. You need to tell them something that's related to speech that they could benefit from. Okay, discharge plans. Discharge plans are so important. Discharge plan, all companies, especially HMOs, the first thing they want to know when a patient is admitted and you have to get prior approval, the first question they ask is, what's the discharge plans? Discharge plans are important because a patient that's going home is going to require something a little bit different than a patient that's staying in the facility. And your treatment plans and your goals are going to reflect that. But discharge plans is just destination. Is the patient home, SNF, assisted living? That's all you need to write. It's just destination. Now, will every patient have a maintenance plan? Yes or no? Yes. Now, if they're staying in the facility or whatever, now do not document discharge to SNF with the functional maintenance plan. It's fine if you write that, but you just told Medicare that you should have a functional maintenance plan. What if you forget to write it? Because they have, and surveyors have asked for a functional maintenance plan, and we can't find one. Because the therapist was supposed to write. Now, you just gave them some information that had you not written that, they never would have looked for it. And now we can't find it. And the therapist goes, well, I forgot to write it. Well, shame on you, because now they ain't looking for it. So do not write that, because if you write it, they're going to look for it. Now, are you supposed to have it? Yes, but let's not give them additional ammunition to shoot us down for. Just discharge plan is just simply destination. Home, SNF, assisted living, and that's all you need to write, okay? And please know that when discharge plans are unknown, write where they are now. If they're in a SNF, remain in SNF, remain in assisted living facility. And then when the because that's where they are now, and they're going to stay there until they decide if they're going to go anyplace else. So when they don't know, put wherever you are, that's where they're going to stay. When the discharge plan changes, that's when you document where they're going to be going. Family has informed you that patient will be going back to assisted living facility. OT, PT, ST, discharge destination, all three must be the same. How many times on the same patient? PT saying they're staying in the SNF, speech therapy saying they going to Chicago to live with their cousin, and OT saying, I don't know. Oh, gee, that happens. You see that. That is so frowned upon. That tells Medicare that you all are not collaborating. You have no idea where the patient's going, which means that if you don't know where they're going, the goals that you've established for them may not be appropriate. And that's why discharge plans are so important, because a patient that's going home is going to have to do a little bit more than a patient that's staying in the facility. They may have to write checks, cook, wash their own clothes. People in a nursing home don't have to do that. So that's why discharge planning is so important.